Today, we are excited to be joined by Carolyn Trapp. Carolyn is the Director of Diabetes Education and Care with the Physicians Committee for Responsible Medicine, also known as PCRM. PCRM is a Washington, D.C. based nonprofit organization dedicated to promoting preventive medicine, especially better nutrition and higher standards in research. She is also a nurse practitioner specializing in the care of people with diabetes with more than 20 years of experience. Carolyn is passionate about the need for and potential for a new paradigm for the prevention and treatment of type 2 diabetes. Her work has taken her to China, the Republic of Macedonia, the Marshall Islands, across the US, and deep into Native American country, where she has seen firsthand what has not worked and what does work to maintain and restore health. Thanks for taking the time to be here with us today, Carolyn.
Thank you, Robbie, and thank you, Cyrus. I'm so excited to be joining you and your work with mastering diabetes.
You have so much experience, and we're really glad to have you with us. So why don't we get started with your history? How did you get into working with diabetes and diabetes patients?
Really, as life sometimes goes, it was just a happy coincidence. My first position out of when I graduated from the University of Michigan School of Nursing was on a unit that did diabetes and wound care. And I really found working with people with diabetes to be really interesting, and decided I wanted to know more. And I had the opportunity to become a certified diabetes educator. So I got in the hours, doing education with patients and doing all the studying, passed the board exam, moved around to a couple of different places, and always found that having that CDE credential opened doors for me. There's plenty of work available if you're a nurse with expertise in diabetes. And along the way, I decided to go back to school and become a nurse practitioner, and moved from inpatient care to community care, doing working in an outpatient program doing diabetes education. And somewhere in there, I met a dietitian who was working with a group of internists. And she said, every patient who comes in the door has diabetes. And I think this group could really benefit from having a diabetes educator. And one thing led to another. And we decided we'd try it out 4 hours a week. And really quickly, 4 hours a week in an internal medicine practice, seeing people with diabetes wasn't enough. So we added more hours. When I became a nurse practitioner, I thought I was going to do more, I was going to see all patients, right? My degree's in adult primary care. And after about a year of trying to be a generalist, I said to the doctors I work with, I really just want to work with people who have diabetes. I mean, personally, I found the disease fascinating, compelling. I found that the needs of patients who came in were so broad. I mean, people need expertise, knowledge in this disease. They need support for behavior change. They need emotional support. And I love doing that work. And I was a little nervous to tell the doctors I worked with that I wanted to be a specialist. And they were really tired of telling me which antibiotic for which infection, or some other thing that I just could not master. So they were in support of that. So now for over 20 years, I've been specializing in the care of people with diabetes in a primary care practice. I also, about 13 years ago, learned about the work of Dr. Neil Barnard and the Physicians Committee. And it was prior to that time, I had really a life-changing epiphany. In the practice I worked at, I had the ability to write prescriptions for patients, and we use medication really aggressively. I had people on multiple daily injections with type 2 diabetes. I had people on insulin pumps, and we could get really good numbers, but I was still seeing people go on to develop kidney problems or heart disease or loss of vision, even with their good numbers. And that was really different than what I'd been taught. And it was frustrating to me and concerning to me that medications weren't making a big difference. And it was around this time I learned about the benefits of plant-based eating and started sharing that with my patients. And I started seeing I could help people get off of medication or greatly reduce their medication. And the benefits went beyond glycemic control. They also, people who had joint pain were finding that their arthritis didn't bother them as much. Migraine headaches went away. Constipation went away. And the research was there showing that this also would benefit blood pressure and cholesterol and potentially the other micro and macrovascular diseases that people with diabetes are at risk for. So the docs I work with encouraged me to keep offering this. And I was lucky enough to meet Dr. Barnard, who after a year of correspondence and having the opportunity to try out his protocol that he used in research studies with my patients, I was offered a position. So I've now been the Director of Diabetes Education and Care for the Physicians Committee for almost 13 years.
Wow, that's awesome. Actually, you're in a really unique position here because you have a lot of experience living with or working with people with all forms of diabetes. And you're a nurse practitioner plus a certified diabetes educator. So, you, I think, have a real good insight into a lot of things that maybe a typical MD wouldn't necessarily. So one of the things that I find kind of fascinating here is that, you travel around the world teaching, health councils of different countries how to help people prevent and reverse diabetes. And you're very well traveled and you do this, in many different locations. But you and I both know the standard of treatment around the world for diabetes has nothing to do with a plant-based diet. Yet, hopefully yet. So can you give us some insight here into what is the actual standard of care that doctors and nurses and CDEs are required to follow when they see a patient present with prediabetes or type 2 diabetes in a clinic?
Sure. It's a great question. And before I begin criticizing the guidelines, I do want to make the point that the guidelines say that lifestyle changes should be the first intervention. Unfortunately, the guidelines often aren't specific enough in what should a healthy lifestyle be, or how can clinicians get their patients on that road and help them to sustain it. Guidelines also often don't remind clinicians that throughout the course of the disease, we need to keep talking about lifestyle. But it is in there. So as I said, though, it just doesn't go far enough. The usual standard after attempts of lifestyle change are made are to prescribe, for somebody who's newly diagnosed with type 2 diabetes, is to prescribe a pill called metformin. And after 3 months, if blood sugars are not better, if there's not improvement in A1C, to add a second agent. And then down the road, if the numbers aren't good, to add a third agent. And anywhere along the way, if the numbers are too high, you can add insulin or an injectable. Or you can start with insulin if the numbers are really high. And year after year, these guidelines come out, and they're many pages long, and I'm referring to the guidelines from the American Diabetes Association or the American Association of Clinical Endocrinologists or the VA Department of Defense. There are a number of different guidelines that are commonly used in the US. What I see is fancier and fancier charts on how to use medications. We now have 12 classes of drugs that work to lower blood sugar. When I got into this, there were sulfonylureas, pills that people know of as glimepiride or glyburide or diabeta, micronase. So that was one. And the second class was insulin. now there's 12 classes, and within those classes, there's multiple choices. And I find this true at medical conferences, that often there's maybe a lecture or two on lifestyle or diet, and many lectures on pharmacology and on all these different classes of drugs, because clinicians are struggling with, which one do I use first? Which one's the best? How do I combine these drugs to get better numbers? So the standard is really to use medication aggressively to get at these good numbers. Interestingly, this year, the American College of Physicians came out with a new guideline for clinicians, and they recommended de-intensifying medications. They recommended a higher target A1C range for most people with type 2 diabetes. Their recommended target range is an A1C between 7 and 8%. And that's a lot higher than most clinicians think is good, than many patients have been taught is good. We've all heard intensive control is best, lower than 7% is best. So this was really radical. And the American College of Physicians, as you can imagine, were not necessarily all greeted with great enthusiasm from the other professional organizations. However, I think they're on the right track. I think we have real problems with the number of people who experience hypoglycemia from over-medication use, especially older patients. Just no reason to push the numbers down with medication. There's no problem at all with getting lower numbers with lifestyle, but these medications are problematic. So I see a real need for a change in the standards of care in terms of where the focus is. Let's shift the focus to the benefits of lifestyle and figure out how can we help our patients make those changes and sustain the changes.
Okay, so this is actually really cool because before we get into the lifestyle side of things, which I know you're an encyclopedia at, let's talk about the side effects of a lot of the oral medications, these 12 classes of drugs that you just brought. My gut tells me that the reason they decided to de-intensify the medication regimen is likely because the number of side effects was starting to creep up over the course of time. Is that the reason?
Well, that's one reason. Another reason is cost. The patients are complaining about the cost of medications. If the medications were effective at preventing expensive complications or life-threatening complications, it would be one thing. But this is really interesting, and I'm going to read it because I just wrote this for a paper I'm working on. That there was a meta-analysis, which is when you take multiple studies and you combine the results, multiple similar studies. 13 randomized controlled trials found that intensive glycemic management with medications resulted in doubling of the risk of severe hypoglycemia and other side effects, with no overall mortality or cardiovascular mortality benefits. So, we're putting people on all these medications and not getting benefits. One big concern is weight gain. This is really depressing for a lot of people with diabetes. With type 2 diabetes are overweight already. And to find out that their medication is causing them to be hungry and increasing their weight, or causing them to retain fluid and causing weight gain, that's worrisome. There's one class of drugs that can raise the risk of fractures, pancreatitis, vaginal yeast infections, urinary tract infections. It's really important that people who receive a prescription for medication, or actually before the prescription, ask the provider, what are the risks of this drug? What kinds of side effects happen? And, that was the wake-up call for me. Was my patients were complaining about the costs, they were complaining about the side effects, and it just started to make me question, what am I doing? I've got this prescription pad and I can get people on medications, but if they're not getting better and I'm causing these problems, something's not right.
Okay, so clearly it's best to try and avoid these medications as much as possible. So in your experience, is it possible for people following a low-fat, plant-based whole food diet to reduce or eliminate oral medications and or insulin?
Yeah, so that's the amazing thing is when I've seen people who were on multiple injections of insulin during the day or high amounts of insulin. I have a patient who was on over 200 units of insulin a day. At that point, and he'd had diabetes more than 10 years. At that point, based on what I'd learned, I would have said, his pancreas is not making enough insulin anymore, and he'll probably always need insulin. And interestingly, even with over 200 units of insulin a day, his A1C was over 10%. So even all that insulin wasn't helping. If somebody like that can get off of medication, off of all medications, he doesn't need diabetes medications, he doesn't need blood pressure, cholesterol medication, antidepressants, medication for erectile dysfunction. I mean, the list goes on and on. Yeah, lifestyle's really, really powerful. And I wouldn't have believed it if I hadn't seen it myself. Often in my work with the Physicians Committee, and I have the privilege of talking to groups of prescribers, clinicians about what's possible, I often hear, oh, but you don't know my patients. That might work in the part of the country where you're from, but my patients aren't willing to make those kind of changes. And what I've found over and over is that I can't tell by looking at a patient if they're going to be willing to make this change or successful with it. It happens to me all the time where I'll say to somebody, your numbers are high, or you're having these side effects, or you're concerned about the cost of medications. I've had some great successes with my patients changing their diet. Would you like to know more about that? So I ask permission, and many times they say yes, they're really interested. And that's when I'll tell them about the power of diet, about how people around the country, people around the world actually, eating more traditional diets didn't develop diabetes, and that we have this standard American diet that's so unhealthy. And for many people, it's a matter of learning some new skills, learning some new recipes, enlisting the support of friends and family. And yeah, it is possible. So it's a really hopeful message. And that's very different. Often healthcare professionals find diabetes really challenging and depressing. It just seems overwhelming what's involved to manage the disease with our current paradigm of multiple testing, multiple medications, counting carbohydrates or weighing or measuring portions. It's just this intensive system of management seems really overwhelming. And when you have patients who either aren't willing to do it or have tried and haven't experienced success, it's discouraging. My experience is the complete opposite. I find that people get excited about what's possible and what they find for themselves, and this recognition that diabetes, as Dr. Barnard likes to say, it's not a one-way street. It doesn't have to mean you're on the road to suffering all these complications. It can be a wake-up call, an opportunity to reclaim health, to put in place healthy habits that make people feel good every day.
It's so great to hear you say that, because Cyrus and I, we feel the same way. It's so exciting to work with people living with diabetes because we can see results so quickly, and they're objectively testing their blood glucose on a regular basis. And we know that they're seeing improvements, which is really fun. So one thing I just want to ask in addition to that question is, when somebody started to listen to your recommendations, even if they didn't go all the way, have you ever seen it not help somebody?
I have to say, I think that everybody benefits. At the same time, not everybody is successful at making the change and sticking with it. And unfortunately, in primary care, we're not really set up to provide the kind of support that people really need. I can refer people to great resources. You see the books behind me. There's great resources online. But some people can be really successful opening a book. Dr. Neil Barnard's Program for Reversing Diabetes is a wonderful book. Came out 10 years ago, was just re-released. And one of the great joys in my work with the Physicians Committee is when that book first came out, I got to read letters that Dr. Barnard got about how people read this book and changed their diet and got better, got off of medication. So for some people, that works really well. Your program online is a phenomenal resource. And for people to have access to a community and to have access, 24/7 to people who can answer questions and connect them to resources, to recipes, to support, that's the kind of thing we need. Unfortunately, not covered by insurance. Patients don't have a mechanism right now to pay for these kind of, unconventional or new innovation. And that's really where we need to see some changes. I would love for my patients to be able to have local cooking nutrition classes that are covered by insurance. And I will mention there are classes all over the country, all over the world actually, called the Food for Life program that was developed by the Physicians Committee, and I know has been helpful to many, many people in trying out new recipes, learning the skills to do cooking. And that's a tremendous resource. And if you'll allow me, I'll share that the website is FFL Classes, foodforlifeclasses.org. And people can log onto that website and see where in their area there's a class. Another great resource is Physicians Committee 21-Day Kickstart Program. And that's now an app for OS and for Android phones. And it's free, 21 days of meal plans, recipes, celebrity videos, grocery lists, all that stuff is great. So yes, the answer to your original question, does this work for everybody? Everybody who does it, yeah, it has some benefit. It might not mean that they can eliminate 100% of medication or that they reverse their diabetes, but many, many are able to see tremendous benefits. And as I mentioned, the benefits are not just in blood sugar control, but all these other health benefits.
This is awesome. Let's change subjects here just a little, real quickly here. You've worked a lot with the Native American community, and have helped people in the Native American community really start to understand how they can make dietary changes for improved diabetes health. So, can you go into a little bit of detail here about which specific population you're working with and what types of positive change you've been able to promote?
Sure. So let me back up a little bit, and I'll tell you the story of how I ended up working with Native Americans in the Southwest. Given that I live in Michigan, the Physicians Committee is in Washington, D.C., people are often really surprised to hear that I do this work. So 12 years ago, Dr. Barnard was on a radio show that was airing in the Southwest. And he was talking about this new research at the time on a plant-based diet for diabetes. And a woman called into the show and said, it sounds like the diet that you used in your study is similar to the traditional diet of Native Americans, which is often called the Three Sisters. What are the Three Sisters? They're corn, beans, and squash. Three foods that grow together really well and that taste delicious when you eat them together. And it planted a seed in Dr. Barnard's head that maybe this research would be of interest to Native populations. So I was in a nutrition department meeting and he said, I'm going to do some outreach with the Navajo tribe. At the time, it was the largest tribe in the U.S. Now it's over 300,000 people. And who's interested in joining me? And since I have diabetes in my job title, I thought, well, I should volunteer. So the next thing I know, I'm on a plane and meet Dr. Barnard, and we've got a couple of lectures set up. One in Window Rock, Arizona, which is like the Washington, D.C. of the Navajo Nation. Population 4,000. Their Department of Health employs 1,100 people. 80 are involved in preventing diabetes. And we'd been invited to speak to them, talk about the research, talk about practical aspects. And we did that, and there was interest in learning more. What we proposed, on the one hand, though it sounds familiar. We're talking about foods that they know about. We're saying corn is a good food. It's a whole grain, whereas conventional diabetes care teaches corn is a carbohydrate. You have to limit the amount of corn you eat. So in that respect, I think that opened some doors for us. We had a different approach. At the same time, we were saying, leave the meat off the plate. Don't drink milk. Don't eat cheese. And of course, some people didn't want to hear that message. So we were delighted to find that there were people who wanted to learn more. And we offered for anyone who wanted to that I'd get on the phone once a week for 10 weeks. And we'd help people make a diet change and try it out. And we had 30 people on week 1, and we had about 3 people at the end of the 10 weeks. But those three people went on to become our champions. And we developed a curriculum. We trained others to teach the curriculum around the Navajo Nation, and also with a college, Native American college in Santa Fe, and at a site in Albuquerque. And we had graduates of that class do well. And the word started to spread that this is an approach that works. Another really interesting thing about Native Americans is people often think the reason that they have such high rates of diabetes is because of their genetics. You know, they have bad genes. And it turns out that's just not true. When there are tests of genetics of tribes in Arizona who originally came from Mexico and have the same genetic lineup, what has been determined is that there's no difference in genes, it's just difference in lifestyle. And we see huge rates of diabetes of those Native Americans on our side of the border as opposed to those indigenous people who remain in what's Mexico. So it's not the genes, it's really the lifestyle. And there's also this history of moving Native people off their lands, interfering with their access to water, all sorts of historical trauma that have led them to often rely on the Food Commodities Program, which provides them with things like canned meat and blocks of cheese and some fruits and vegetables and some beans, but has really gotten people hooked on these problem foods. You know, until about 6 or 7 years ago, lard was included in that box of commodity foods that people got. So we've got this set up. You couldn't design a diet better for getting a population to develop overweight, obesity, diabetes, lots of different cancers. So because of all of that, I think that the people that we worked with on the Navajo Nation were really willing to try something new. And because of that, invited us to continue to do this work and kept inviting us to come back. And it's been really encouraging to see the results. So would you like to hear about what's happening at a hospital on the Navajo Nation?
Please, yes, tell us.
Okay, so there is this wonderful Navajo hospital in Fort Defiance. And at that hospital, there is a woman who runs the cafeteria. Her name is April James, and I am really proud to call April a friend. About a year and a half ago, we did a program with the vice president of the Navajo Nation, Jonathan Nez, who has his own success story. Vice President Nez, who's now President-elect Nez, and by the time this program airs, will be the president of the Navajo Nation. He tells this great story about how every year he'd go to elementary schools and talk to kids about eating healthy and being active. And one year, a fourth grader said to him, you come out here all the time and tell us this, but every year we see you getting bigger and bigger. And he was quite overweight at the time. Well, he took this story to heart and he decided he was going to make some changes. And he did. He started eating differently and he started walking and then he started running and he's lost 80 pounds and he's kept it off. So part of his platform as vice president was behavior change and getting people running. But along the way, he recognized that not everybody could run. And unfortunately, overweight, obesity is really epidemic among people on the Navajo Nation. So he turned to us. He was really interested in our nutrition message and the resources that we had developed with Navajo nutritionists. And we were invited to start sharing resources, and we did a 4-week challenge with the employees in the vice president's office. And we had 18 employees who tried this out and did really well. Okay, so that's the first part of the story. I mentioned April at the hospital. In one of my visits, I was invited to come and meet with a dietitian at the hospital. She introduced me to April, and April was at a really interesting point in her career. She'd been working at the hospital for 13 years, was concerned about her weight, her health, concerned about the health of people who worked at the hospital, and was intrigued by this 4-week challenge with the vice president's office. And we came up with a plan to do it with employees at the hospital. And what April had to offer was not only would we get a group of employees together, but she would start offering plant-based meals in the cafeteria. Now, I'm sure I don't have to tell you that you go into most hospitals across the country, and to find a plant-based meal is not always an easy thing to do, which remains mind-boggling to me. But April at the Navajo Hospital decided that that's what she was going to do. So we worked together. We trained 18 cooks in how to do plant-based cooking. And she and her cooks developed a menu, and every day they have a plant-based breakfast and a plant-based lunch available. They serve over 1,000 meals a day at this little 35-bed hospital. People come from all over. And during this 4-week challenge for employees, where 50 employees of the hospital signed up within the first hour of an email going out, people were really interested in this. Over the 4 weeks, people lost weight, blood sugars got better, cholesterol got better, people felt better. So April's now working to keep this going, and they continue to offer plant-based meals, and she's got some ideas. I don't want to say too much more because she's working her from the inside in gaining support for making additional improvements. But if a hospital on the Navajo Nation can make and serve plant-based meals and see immediate improvements in the health of their staff, and find that people are willing to make this diet change in a place where they don't have access to affordable produce year round, where people often have to drive a long way to get to food, where either because of the SNAP program or the federal distribution to Indian program, they're getting foods that are not healthy, where there is a limit of grocery stores and there are these little convenience stores that don't offer fresh fruit. If there is support for plant-based eating there in that community, we should be able to get people to make these changes all over.
This is very, very encouraging. And I know the work that you guys have done, that put a lot of effort into that, and you've made a lot of really good, big change. Now, the last question we have before we go today is about the challenges that arise when people try and make lifestyle change. We know it's hard. We know it's difficult. You talked about how you started the 10-week program with 30 people and 3 people were there at the end. So what challenges do you see people run into and how can they overcome them?
That is a great question. And I have to say that I love this line that the Michigan Department of Health used to use in a campaign to help people quit smoking. They would say, don't quit quitting until you've quit for good. And I think the same is true for many who are trying to make diet change, that it's okay to have slips and falls. And perfection should not be the goal. In fact, perfection can really get in the way. That I think that as a clinician, I want to encourage people to get on this road and to start the process of learning all they can and building a toolbox of resources. That toolbox includes books, it includes new recipes, it often includes new friends, people who are also interested in making a diet change or who are already doing it and can provide support. It can be finding classes. It can be finding healthcare professionals who are interested and supportive, and reaching out for the resources that are available to people to recognize that ongoing support is really important. We have a program in Michigan called the Plant-Based Nutrition Support Group, and it was started by Paul Chatlin, a guy who had heart disease, and he was lucky enough to learn about Dr. Esselstyn's program just prior to having a stent placed in a coronary artery. And he made this diet change and he decided he wanted to share this with other people, and he put up a flyer for a meeting. And that little group that came to the first meeting of people who'd watched the movie Forks Over Knives has grown to a community of over 6,000 people here in Michigan. There is tremendous interest in this, and nobody has to feel that they have to do it all alone. Reach out, find others that are doing this to help you to be successful.
100%. It's funny because a lot of the times we like to joke around about the fact that lifestyle change is very simple and it's very hard at the same time. The principles of what to perform, what actions to take are actually very straightforward. Try and minimize your animal product intake, minimize or eliminate altogether, eat more fruits, eat more vegetables, eat more legumes, eat more whole grains, move your body, try to reduce your stress level. It's a relatively straightforward prescription that's been true for ever since human beings started living, thousands of years,
right,
or more. But yet the mechanics of actually going about that, especially in the society in which we live, in which things are, the lifestyles that we've been leading up to this point are not congruent with that. In fact, they're almost sort of the exact opposite. There's a lot of stress. There's not very much movement. And there's a whole bunch of packaged and processed and refined foods in the grocery stores that are constantly, speaking to us and making us more addicted to them. In addition, there's plenty of meat available, plenty of dairy products available, plenty of these low carbohydrate foods available. And there's plenty of mass information, which is telling us that that's actually the right foods, the right combination of foods to be eating. And I think that's where people get misled and a little bit concerned. Oh, wait a minute. I heard that eggs were good for me. I heard that eating meat was good for me. And now you're telling me to do the exact opposite, right? So it gets a little...
Sure.
But that's a long-winded way of me saying thank you for doing the frontline work and putting in the time with patients, for writing, contributing to journals, to educating other practitioners, how they can start to help teach their patients how to move towards a low-fat, plant-based diet. It's really just this is not easy work to do, and you're so eloquent in your descriptions, and you're so good at being able to motivate and inspire others. And, we really appreciate the time that you've taken to be with us here today, and we just appreciate, all the work that you've done. So thank you so much. Thank
you very much. And I want to say a huge thank you to both of you. You've really filled a void. I so often refer people to your podcast, to your Facebook page, and I love being able to connect people to both of you, because you also are living proof to that there is hope around the world of diabetes. Also, if I may, I just want to give a shout out to my nursing colleagues. I put on my button that says Nurses Heart Plant-Based Nutrition. And, within the world of healthcare, the nursing profession is the largest healthcare profession. And Florence Nightingale was the very first nurse, and within her writings, she talked about healthy eating. So this is really a part of what nurses should be talking about and should be doing. So I'm delighted to be doing this work, and I also want to encourage others in the nursing profession to get involved, to come to the Physicians Committee conferences, to come to PPOD, the Plant-Based Prevention of Disease Conference, to continue this education and to be involved in this work. Thanks.